Picture this. It's 3 a.m. in the ICU. Your post-cardiac surgery patient was stable an hour ago. Now their blood pressure is crashing, their neck veins are bulging, and when you put your stethoscope to their chest, the heart sounds are barely there. You have minutes to act. Would you know what to do? Today we're going to make sure you do. Welcome to Critical Care Simplified. I'm Patricia Ann Sutherland, and in this video, we're covering everything you need to know about cardiac tamponade, from the pathophysiology all the way through to your nursing interventions. Let's dive in. Let's start with the basics. The heart sits inside a protective sac called the pericardium. Between the heart and that sac is the pericardial space. Normally it holds just 15 to 50 milliliters of fluid. That small amount of fluid allows the heart to beat smoothly. Cardiac tamponade happens when fluid accumulates in that pericardial space, and it accumulates fast. As fluid builds up, pressure rises. That pressure squeezes the heart from the outside, preventing the chambers from filling properly. When the heart can't fill, it can't pump. And when it can't pump, cardiac output drops dramatically. Here's the key insight. Even a small amount of fluid can cause tamponade if it accumulates rapidly. The pericardium is a rigid sac. It can't stretch fast enough to accommodate sudden fluid buildup. So what causes this fluid to accumulate in your ICU patients? The most common causes are trauma or penetrating chest injury, post-cardiac surgery, this is huge in the ICU, malignancy, especially lung and breast cancer spreading to the pericardium, pericarditis from infection or autoimmune disease, patients on anticoagulants or with bleeding disorders, and invasive cardiac procedures like central line placement or pacemaker insertion. Your highest risk patients, post-op cardiac surgery patients, trauma victims, anyone on blood thinners, and patients with known malignancy. Keep these patient profiles in your mind. They need extra vigilance. Now, let's talk about recognition. The classic presentation is Beck's triad, and you need to have this memorized. Beck's triad, hypotension, jugular venous distension, those bulging neck veins, and muffled heart sounds. If you see all three together in an at-risk patient, cardiac tamponade is at the top of your differential until proven otherwise. Two more classic findings to know. Pulsus paradoxus, that's an exaggerated drop in systolic blood pressure greater than 10 millimeters of mercury during inspiration, and compensatory tachycardia as the heart tries to make up for the falling cardiac output by beating faster. But here's what makes tamponade tricky in the ICU. Not every patient will give you the classic triad. Sedation, mechanical ventilation, and complex comorbidities can mask those signs. So you also need to recognize the subtle presentations. Watch for unexplained, persistent tachycardia, often the earliest sign, a rising central venous pressure or CVP trend, decreasing urine output as renal perfusion falls, altered mental status, restlessness, confusion, decreased responsiveness, and difficulty weaning from the ventilator due to hemodynamic instability. Your systematic bedside assessment. Start with overall patient appearance. Check vitals, BP, HR, respiratory rate, SpO2. Look for hypotension and tachycardia. Do your cardiovascular exam. Listen for muffled heart sounds. Check for JVD. Assess for pulsus paradoxus. Use point-of-care ultrasound if available. And communicate your findings to the team immediately. The two key diagnostic tools you need to know are the EKG and echocardiogram. On the EKG, look for three things: low voltage QRS complexes. The complexes look smaller than normal because the fluid is dampening the electrical signal. Electrical alternance, this is pathomnemonic when present. It's a beat-to-beat alternation in QRS amplitude as the heart literally swings back and forth in the fluid-filled pericardial sac, and sinus tachycardia as a compensatory response. You may also see nonspecific STT changes and PR segment depression in pericardial disease. Now, echocardiography is the gold standard, and point-of-care ultrasound at the bedside has become standard in ICU practice. Here's what you're looking for on echo. First, a pericardial effusion, that anechoic or dark space surrounding the heart. Second, right atrial collapse during systole, one of the earliest signs. Third, right ventricular diastolic collapse, highly specific for tamponade physiology. Fourth, respiratory variation of ventricular filling, the echo equivalent of pulsus paradoxus. And finally, a dilated non-collapsing inferior vena cava, indicating elevated right atrial pressure. Other supporting tools, chest x-ray may show that classic water bottle heart silhouette if the effusion is large. Hemodynamic monitoring classically shows equalization of diastolic pressures. Elevated lactate tells you perfusion is compromised. Remember, integrate everything: the clinical picture, the EKG, the echo, and the hemodynamics. No single finding clinches the diagnosis. It's the constellation that guides you. When you suspect cardiac tamponade, here is your immediate action sequence. Step 1, recognize and report. Call your provider or activate the rapid response team right now. Don't wait for confirmation. Act on your clinical suspicion. Step 2, ABCs. Assess airway, support breathing with supplemental oxygen, monitor circulation continuously. Be ready to assist with advanced airway management. Step 3, optimize hemodynamics. IV fluid bolus to increase preload and support blood pressure. In severe tamponade, we're buying time. Fluids temporarily improve filling. Step 4, establish large bore IV access. You need reliable access for fluids, vasopressors, and emergency medications. Step 5, continuous monitoring. Cardiac monitor on, frequent vital signs, close watch for any deterioration. Step 6, concise provider report. Use your S-bar. Tell them exactly what you're seeing. Now, the definitive treatment is pericardiocentesis, draining the fluid from the pericardial space. Your role is to prepare for this procedure. Gather the sterile pericardial centesis tray. Ensure the ultrasound is at the bedside. Position the patient at 30 to 45 degrees. Maintain continuous cardiac monitoring throughout and assist the provider while maintaining the sterile field. After the procedure, watch vigilantly for complications. Reaccumulation of pericardial fluid, the tamponade can come right back, arrhythmias from cardiac irritability, bleeding, infection, and paradoxical post-procedure hypotension. Monitor vital signs, drainage output, volume, color, and consistency, EKG changes, urine output, and neurological status. Document everything with accurate timestamps. Let's talk about communication, because in a cardiac emergency, how you communicate is just as important as what you know. Use S-bar every time. Situation: my patient in bed 4 is acutely hypotensive with a BP of 80/50, tachycardic at 130 with JVD and muffled heart sounds. Background: he's post-op day 1 from CABG. Assessment: I'm concerned for cardiac tamponade. EKG shows low voltage and echo shows a pericardial effusion. Recommendation: I need you at the bedside now. Closed loop communication. Confirm orders back. State urgency clearly, don't soften it, and trust your instincts. You have a duty to escalate, even if it feels uncomfortable. Know your team. The intensivist leads medical management, respiratory therapy manages the airway, pharmacy prepares your emergency medications, and the charge nurse coordinates unit resources. Everyone has a role. Keep information flowing clearly among all of them. Let's wrap up with your key clinical pearls. 1. Know your at-risk patients. Post-cardiac surgery, trauma, anticoagulated, malignancy. Keep tamponade on your differential for every one of them. 2. Beck's triad is your cornerstone. Hypotension, JVD, muffled heart sounds, but don't wait for all 3. Tachycardia alone in an at-risk patient warrants heightened vigilance. 3. Electrical alternance on EKG is highly specific. If you see it, act fast. 4. Point-of-care echo is your best friend. Right atrial and right ventricular collapse confirm tamponade physiology. 5. When in doubt, call for help. Your job is to recognize and escalate. The team handles the rest, together. Cardiac tamponade is survivable when caught early. Your vigilance as an ICU nurse is what makes that possible. Thank you for watching Critical Care Simplified. If this video helped you, please give it a like, subscribe for more ICU education, and share it with a fellow nurse who needs it. Stay curious, stay compassionate, stay competent. See you in the next one.